Hello, everyone. Today we will talk about anxiety, OCD, and sleep wake disorders. So there are three topics in one lecture. We'll start with anxiety. So as we know that anxiety is pretty much universal human experience. Um, I don't think I have met anybody who has never felt anxious in their life. It's a very one of the most basic emotions that we have. It's a part of it. We believe it's a part of evolutionary. Um, what do I mean by that? So when we used to live in the jungle, we had to develop a skill um, to register some kind of threat to see if it's a safe to walk in front of a tiger or a snake or eat this leaf or not. So we had to register all that and remember that threat. So anxiety is a part of a survival skill. It keeps you away from harming yourself or harming someone else. If you are nervous, scared, you would rather stay home. Um, so it's a part of survival, right? What is anxiety? Well, it's a state where a person feels a strong sense of uneasiness, some kind of nervousness, stick to stomach, butterflies. And it's all apprehension to anticipation of danger. Remember, there's no real threat right now, but you're anticipating that. Um, Anxiety is frequently accompanied by autonomic nervous system type of symptoms. So when you are in a sympathetic nervous system, under the influence of sympathetic, so you will see tachycardia, respiratory rate is going to be high, your blood pressure will go high, and you feel some GI symptoms, nausea, vomiting, upset stomach, and so forth. Overall restlessness, syncope. But remember the key word, without having a specific source or reason for the emotion. So there's a difference between a real threat, in case of uh, some natural disaster, or indeed you're standing in front of threat. That's real, so that makes sense. That's not a pathology. But here the issue is it's all about perceived danger. It's all about a perception. You're anticipating that danger or that threat, but it's not real. um, it becomes a pathology when these symptoms interfere with activities of daily living. Okay, I do want to introduce a very like a basic relationship between these three items: anxiety, depression, and insomnia. All three of them may have some overlapping symptoms. For example, a client who have some degree of anxiety may report that I cannot concentrate. It's not possible to actually concentrate when you're very, very anxious, when you're nervous. I'm sure you know that. A client may tell you that I can't sleep. So insomnia, or inability to sleep, can be a symptom of anxiety, can be a symptom of insomnia. And we also know when the client is depressed, that client may not be able to sleep and may not able to concentrate. All three individuals may complain fatigue. They don't feel good, right? They're tired. You can only imagine if the client has true primary insomnia, that client is going to report fatigue. Same thing with the depression. We already talked about that concept. Okay, so the point I'm trying to make here is that sometimes you have a client that comes in with very generic, vague symptoms that I don't feel good, I'm tired, I can't sleep, I can't concentrate. It is our responsibility to really ask appropriate questions and try to find out that what exactly we are dealing with. Is it really anxiety? Is it depression? Is it insomnia? Or a combination of two, or all three? That's possible. You may have a client with all three of these disorders. So what are some core symptoms that will distinguish one from the other? Well, when you talk to your patient, and then if you believe your working diagnosis is anxiety, then see if you can focus on these two. Of course, we will never put words in our patient's mouth, right? We want to ask kind of open-ended questions and see if they can give us some clue. So we always want to ask, tell me more about when you say you cannot sleep. Tell me what's going on. Tell me more about that, instead of saying, um, do you think you're anxious? So don't say that, right? So if a client gives you um, some complaints or some clues that perhaps there's a fear or a component attached to it, or the client is worried about something, then you're dealing with anxiety. But if the patient tells you, no, I'm not scared of anything, I don't think I'm nervous, I'm not worried, um, I'm okay, but I just can't sleep. So perhaps then we are really talking about insomnia. And then you ask, how many hours are you sleeping? And they tell you, well, 5 or 6, but I'm very, very tired the next day. And then that's your chief complaint, perhaps fatigue and can't sleep. So they're dissatisfied with the quality or the quantity of um, sleep. And then see if the patient is giving you these type of symptoms. Are you depressed or loss of interest? We already talked about that concept. If this is the part of the main issue, and therefore the patient cannot sleep, then perhaps we are really dealing with a primary depression. Now, as I said, you may have a combination of all three, but see if you can really, next time when you see a client, see if you can put them in these three categories and really dig further to find out if you're really dealing with anxiety, depression, or insomnia. Okay, so when we say anxiety is natural, or it's a learned behavior, and we do not forget that episode, and I said it has to do with survival, it's evolutionary. So where does that fear lives? Well, it lives here in the amygdala. So look at this right here, the tiny little um, organ right near the hippocampus. This is where we register fear. It lives here pretty much. Now, what happened is amygdala will share key information with the rest of the brain, if you will, with the orbitofrontal cortex, and that will regulate emotions. So fear is more than just a feeling. It can include a motor response as well. For example, when you see a snake or any kind of a threat, you just don't say that, or you don't just feel that, oh, I'm scared. You do something about it. So there's actually a motor component to it. You either fight, flight, or freeze. Amygdala will also communicate with hypothalamus. What will happen is it will change, it can cause the changes in your hypothalamic pituitary adrenal axis, which will release a stress hormone, cortisol, which we know that it's made from adrenal gland. So see how everything is connected when you are under stress. So you are releasing stress hormone because you believe that there's a real threat, when in reality there isn't any, right? um, it's a good mechanism. If you were indeed standing in front of a danger, then of course you need that stress hormone so that you can really run and do something, right? So this increased level of cortisol hormone will help with the survival during a real threat. However, a long-term increased level will result in some chronic issues such as diabetes type 2, coronary artery disease, CVA, and so forth. So that's one problem, right? Second problem is, um, well, let's back up for a second. Amygdala will also communicate with the brain stem, and it will result in increased respiration to prepare for survival during fight, flight, or freeze. Now the problem is, this is a good thing if it's a real threat, but in case of perceived danger, not real danger, now you're really increasing your respiratory rate. So hyperventilation, you may pass out. Amygdala also communicates with ANS, autonomic nervous system, to increase heart rate, blood pressure, and so forth. However, a long-term inappropriate trigger of autonomic nervous system during chronic anxiety can result in same chronic issues: diabetes type 2, CAD, atherosclerosis, hypertension, MI, sudden death. So if you are under chronic anxiety state, um, as you can tell now, it's never a good thing for rest of the organs, to stay under sympathetic nervous system mode, if you will. So when people say I'm scared to death, it may not be a figure of speech. Now again, every amygdala, this was all supposed to be helping us to register and prepare the body to fight, and it does help us, by the way, when all of a sudden we come across a stress or anxiety, whatever. So it's a good thing. But a client who has a chronic anxiety, their body is under stress all the time, and that is an invitation to several other health issues here. Okay, so what is the etiology behind it? Why all of a sudden some people are registering this type of a threat? Well, there's several factors, if you will, multifactorial, like everything else in psych. And number one is a genetic. Now we have enough evidence, many studies done on twins, to see that a trend in the family, and even first degree biological relatives who have a history of anxiety. They will have, if you have a relative, first degree relative, you are 8 times more likely to have some kind of anxiety than someone else who doesn't have a first degree relative. So that's a significant number, if you will, right? Very high number. Okay, second theory is behavioral theory. It's a learned response to specific environmental stimuli. As I said, fear is something that we learn and we do not forget. We store that. So perhaps a child growing up saw their either siblings or parents or grandparents, how they deal with stress or with any type of a conflict, and what kind of skills they had. So perhaps it's a learned response to it. The third theory is a cognitive theory. Anytime I think of cognition or cognitive theory, I think of thinking. Cognition has to do with the thinking, right? So this theory believes that anxiety disorders are caused by distortions in individual thoughts and perception. In other words, they have learned maladaptive techniques. Remember, mal means bad, right? So maladaptive technique to deal with anxiety. So in other words, they need to undo this and learn some very positive coping skills, right? Okay, now example here is public speaking. It's the cognitive theory will explain that, because we know that there are some people who get very nervous, they get very high degree of anxiety to speak in front of people. Public speaking anxiety is a real phenomena, right? But if you think about it, there's no real threat. I mean, those people are not going to kill you. No one has ever died, I'm not aware of, at least. But people do believe that they truly feel that they're going to pass out, they're going to die. That has to, that comes from that cognitive behavior, that you're thinking, they're over exaggerating and the fear, and you believe you're going to have a very dangerous outcome out of that. Okay, and then another one is driving in the cities. I remember taking care of somebody who actually firmly believed that there's no way she could drive, and it became very evident when her daughter was sick, and her partner was out of town, and she had to take her daughter to see the provider, and so you can only imagine the impact of that anxiety on her ADLs, where she could not drive. And we live in a county where we really don't have a reliable public transportation. So anyways, I always tell people, in I mean, I know a few clients who are scared of flying. That's another anxiety, and sometimes they ask for, like, Xanax or some kind of medication. And I always tell them flying is the safest mode of transportation, in my opinion. You have more chances of dying, traveling to the airport, perhaps. But the flying itself is the safest. But it's easy for me to say, right? But if you're truly anxious, you have that phobia, if you will, you're scared, you're nervous, that small talk may not be helpful. Sometimes they do need medications and CBT, and we'll talk about that in a minute. Okay, another etiology, and my favorite, is neurobiological theory concept. So we believe that there's a problem with HPA axis and overactive amygdala. We just talked about that. Your amygdala is, lighting up pretty much, and then we can see that on the images as well. People who are very, very anxious. So it's overactivation of amygdala. And some neurotransmitters can be imbalanced. The first one here on the list is low level of GABA. As we know that the GABA is considered inhibitory neurotransmitter, remember? So it's a brake pedal. So if you don't have enough brakes, you're going to be more anxious. That makes sense. So remember, GABA is going to calm the cell, right? So you need GABA to relax. And if you don't have enough, you're not going to be relaxed. You're going to be anxious. So that makes sense. And remember, norepinephrine is excitatory. It's a part of your sympathetic nervous system, if you will, right? So you're going to have a high level of norepinephrine. The third one, even though it's not, listed on the list, because on the slide, because it's not directly related, but amygdala is under the influence of a serotonin. So if it's overactivating, you need more to calm your amygdala down. So that's one of the reasons why antidepressant medication like SSRI will help to minimize anxiety, and we will talk about that concept in a few minutes when we cover medications. So just remember, these are the two main key players, if you will, and of course serotonin as well. So overall, it's imbalance between the neurotransmitters. Okay, we can divide anxiety into 4 levels. Level 1 is going to be mild, just normal experience of everyday living. For example, you may have a client who feel anxious when they're going to miss the bus. They may have some mild symptoms like a nail biting, finger tapping, fidgeting, and so forth. So that's your first basic level. Then moderate. If you do not intervene here, you will enter into the second level, if you will, second stage. The focus is on immediate concern. The perceptual field is going to be narrowed. In other words, you cannot really think broad. In anxiety, when taking an exam, you have a maybe the most important exam of your life, maybe it's a, I don't know, final exam or some kind of a board certification exam, NCLEX or whatever the case is, right? So that anxiety is real. That's a moderate. You're only worried about that item here, whatever the task is, interview or whatever. So your perceptual field is going to be narrowed. And you may have some symptoms, mild symptom like GI distress, mild nausea, headache. Now, the third level is severe. The focus is on a specific concern now. The perceptual field is greatly reduced, further narrowed. And now you're going to have your autonomic nervous system type of symptoms, hyperventilation, you feel dizzy, can't sleep, tachycardia. And if we do not intervene, either non-pharmacological interventions like CBT or with the medications, or there's no help, there's no interventions, then the client will enter into the fourth stage, which is the last level, panic. So panic is a sudden overwhelming feeling of terror or impending doom. This is the most severe form of emotional anxiety, and of course you will have severe symptoms. Now you're going to have some behavioral changes, cognitive changes, decline, of course, and some physiological signs and symptoms. Skin is going to be pale, heart palpitations, sweating, hypotensive, shortness of breath, nausea, vomiting, chest pain. Patient may start hallucinating or make delusional statements, so psychosis will be present. It is considered to be outside the expected range of normalcy. There's a disorganization of the personality. All of a sudden the patient will make some bizarre statements. So needless to say, it's your last stage. Something needs to happen. You have to intervene. Otherwise, patient can have a heart attack or severe outcome or pass out maybe. So the cycle will reset at that time. Whatever was causing the anxiety or the panic attack, make sure we stay with the client. Do not leave the client alone at that time. It requires one-on-one observation and of course medical interventions. All right, next we will talk about different types of anxiety disorders. So by looking at them, as you can tell, the common theme is going to be some kind of anxious, right? The client is going to be anxious. There's some degree of fear. They're worried about something, but there is a small difference. So you should be able to differentiate what type of anxiety they have based on the presentation. What are they telling you? So that's why history is very, very important. So when you ask a client, tell me more about that, then we are trying to come up with the differentials and working diagnosis. The way these are arranged is based on the developmental stages, so pretty much based on the age onset. So the first one on the list is separation anxiety disorder. So you do have access to your DSM textbook or the PDF, DSM PDF file in Canvas. I highly recommend you take a look at the criteria. I'm not going to go in depth because there's so many, but I'll give you a very brief description. So with the separation anxiety, you're going to have a client who's going to be very reluctant hesitant to leave an individual person or home. They're going to think something bad is going to happen to them if they were to leave. Maybe car accident, they're going to get sick or kidnapped or lost. And clearly there's some kind of physical distress. Maybe they're having headaches, or nausea, vomiting, or can't breathe, can't sleep. So anyways, so that would be separation anxiety disorder. Then the second is selective mutism. So this is where you have a client who has clearly mastered the concept of communication, is able to speak. So there's no language issue, there's no speech issues, right? But all of a sudden, client has decided not to speak. So there's a failure to speak in specific situation, by the way, wherever that anxiety is. So it could be at school, or during a performance, maybe wherever the child believe or individual. It can happen to adults as well. I do have few patients right now. Their overall, it's because of their depression, actually. They have decided not to speak. So selective mutism, I have seen that many times, actually. Next is specific phobia. As name implies, you have a client who is anxious about a specific object or maybe situation. So this could be, somebody who's scared of either animals or flying, as I mentioned before, and so forth. Then you have a social anxiety disorders. So as name applies, you have a client who gets anxious on a social situations. So this could be, all of a sudden you have a client who get anxious during maybe conversation or meeting new people, or when they're being observed. You may have a child who gets very anxious when somebody is going to talk to them, or a stranger comes home, or a guest, and they're going to have a conversation or observe the client during eating, drinking, and then that gives them anxiety. Of course, public speaking will fall under this as well. Okay, next is panic disorder. We briefly talked about that. Remember, that's your fourth stage of anxiety. So all of a sudden it's unexpected, out of the blue. A client is going to have a panic attack, intense fear, right? And it could be due to anything, right? Whatever their underlying cause is. And this is where you will see very dramatic, sweating and tremors, chest pain, and all those, autonomic nervous system type of symptoms that we talked about earlier. Then next we have panic attack specifier. Under panic attack specifier, what we are trying to do is trying to find out the reason. There has to be some kind of a reason. So in generally speaking, just saying that a client has a panic attack, that is not really a mental disorder, if you will. There has to be a reason. So we should make an effort to find out, is it coming from underlying depression? Is it insomnia? Is it generalized anxiety disorder? It could be a cause of some physical issues, maybe CHF, maybe COPD, like end-stage COPD, maybe cancer. So if we can specify, so the patient will have all the criteria, such as heart palpitation, sweating, and nausea and chest pain. But can you identify, and then also see if we can see if this is expected or unexpected. In other words, if it's a well-documented case and you expect this client, or this has happened many times, that you can kind of sort of anticipate, then that would be expected. And then unexpected would be all of a sudden client has a panic attack, panic disorder, and we have no clue. So that would be unspecified. Okay, number 7 is agoraphobia. So this is where a client will have anxiety about either using public transportation, like maybe train or buses or ships and plane and so forth. A client may have issues at enclosed places, that gives them anxiety, such as theaters, or shopping mall and so forth. Um, anyways, anytime the client is outside of their home, and if that gives them, when they're surrounded by people, especially in a small confined area, then so that's your number 7, agoraphobia. Number 8, generalized anxiety disorder. I'm going to talk about that in a little bit more depth in a few minutes. So I have a slide for that. So I'm going to skip that for now, and then we'll move on to number 9, 10, and so forth. Next is you have anxiety because of some substance induced, maybe either prescribed medication, or either over the counter, or some other drugs that a client may be using. So it's coming from that. So now you really have to ask them, show me your medication list, or is there any other drug substance you're taking that I'm not aware of. Okay, and then of course the treatment for that would be to discontinue that, stop taking that, right? Or is it due to some another medical condition altogether? So the difference between number 9 and 10 is number 9 is being caused by a substance such as maybe alcohol, or cocaine, some opioids, whatever, caffeine maybe, I don't know. But here you have a condition, medical condition. It could be a thyroid issue, it could be some cardiac issues, so you have a disease, or maybe anemia. Okay, and number 11 is other specified. In other words, it's not meeting any of the criteria, it's something else. And unspecified is we don't know what's the cause. It's none of the above, it's unspecified. And anytime we do, rule of thumb is anytime we use the term unspecified, we can use that in case of emergency, so that we can just move on and help our patient. But for our follow-ups and so forth, every effort should be made to really change that and do some further investigation and change the diagnosis from unspecified to something that's more specific. We should, especially if we are the primary for that patient, we should know, after with further testing and an exam and so forth, trying to find out the cause. And sometimes you may not be able to find it. I understand that part. Okay, so here's the generalized anxiety disorder. With GAD, you have excessive anxiety and worry that occur more days than not for at least 6 months. So that's a criteria about a number of events or activities, such as either work or school. And so it's going on for 6 months, and the keywords are anxiety and worry. And the individual finds it difficult to control that. So you're meeting all the criteria. A, B, and C is the anxiety and worry are associated with 3 or more of the following. There's 6 altogether, so you have to meet 3 out of the 6, with at least some symptoms having been present for more days than not for the past 6 months. So it's consistent. These symptoms are present pretty much every day. If a client is a minor, a child, you only need 1 item. So 3 out of 6 for adult and 1 out of 6 for a child. So that's your DSM criteria. So what are those 6 items? Restlessness, being easily fatigued, difficulty concentrating, irritable. Sometimes that's all we see in children. Muscle tension, sleep issues, either difficulty following or staying asleep, or they're not satisfied. And then this is very important. The anxiety where your physical symptoms cause a clinical significant distress. In other words, there's some kind of impact on their daily life, right? Either school, work, home, whatever, relationships. And it's not caused by a substance. We talked about that. So there's no drug use, or maybe hyperthyroidism or any medical condition. So it cannot be explained by any other mental disorder. So the difference between E and F is E is saying there's no other medical or substance issue or medical condition, and F is there's no other mental disorder that can explain these. So you have to be very careful, make sure we rule out something that's more severe. Is this bipolar? Is this psychosis? Or any other different types of anxiety disorders, such as separation anxiety, is it social anxiety, is it a PTSD? So you have to rule out. It's these option D, E, F are very standard way of coming up with your final diagnosis that makes you rule out other physical cause, other mental or other medication that can cause these symptoms. So just remember that for the rest of your life. Okay, so let's say that you have your client in front of you. The client is meeting one of the criterias, either for maybe generalized anxiety disorder or maybe for separation anxiety, whatever the case is. What else can we do besides just a DSM criteria? Well, it requires a complete physical exam, mental status exam, basic lab work, look at their CBC, look at their hemoglobin level, their WBCs, is there any infection going on, any anemia and so forth. You also want to take a look at their liver panel, their creatinine, BUN, so I'll get CMP so that I can get a glucose. You can always check A1C, your TSH level, your UA to rule out any infections, cardiac issues, so EKG, EEG, their sleeping pattern maybe, and so forth. And then I use Hamilton Anxiety Scale. It's available in the public domain. It's rather lengthy. There are 14 symptoms, and then they define for both psychological and somatic symptoms. Anyways, I think I gave you the link. We will do an exercise later, but I just want to show you that this is how it looks like. We will do an exercise on how to calculate the score. Okay, so what's the treatment approach for that? Well, as we know that generally speaking, we start off with the non-pharmacological interventions. So we'll start with the psychotherapy. So it's individualized therapy, one-on-one, and we can do either focus on a behavioral therapy or a cognitive or a combination of a cognitive behavioral, something that we call CBT. Remember when we talked about etiology, I said there's a behavioral theory, there's a cognitive theory. So if those theories are there that explain the cause for anxiety, then we can utilize those theories and develop a therapy based off of those theories so that we can help our individuals. So cognitive theory or gives birth to cognitive therapy. So CBT is based on education. We provide education to the client. The idea here is that the client has anxiety because he or she has learned inappropriate ways of handling life experiences. So that's your maladaptive pattern. And treatment is always a collaborative approach between the client and the therapist. Rather than offering suggestions, I would never tell the patient that I think you should do this, right? We don't do that. We may make a recommendation, but we really want to know what they could have done differently. So we want them to come up with ideas. We will provide some tools and correct them if they're selecting a maladaptive technique. But really, we need to encourage them to come up with that. The client is encouraged to be aware of the thoughts, examine them, and substitute more balanced thought, and eventually develop new patterns of thinking. These therapy sessions are brief. They last, I don't know, a few minutes or so, maybe 20 minutes, and they're 5 to 20 sessions. They're not like a, lifelong therapy sessions. The goal is to discourage the client dependency on the therapist. Client should not be dependent on a therapist. They should be able to learn these coping skills so that they can live their life independently. Okay, next is behavioral therapy, behavior therapy. There are different types, subtypes. You will learn about these in a different course, in a psychotherapy course. But this is just like a brief introduction. Relaxation training or thought stopping technique, that's actually one of my favorite. I recommend that to my clients. So this is where you say stop out loud when the idea comes to your mind. Anytime the bad thought comes to your mind, you can say stop it, just loud, so that it gives you a reminder that I need to stop thinking about that. Nothing bad is going to happen. I need to stop it. Or I also recommend to wear a rubber band on the wrist and just snap that. So it's going to be painful a few times, but that'll be a reminder that I need to stop thinking. I tell my clients, so when you have that bad thought that's giving you anxiety, does it help if you keep thinking, or does it help if you stop thinking? If something is giving you pain and suffering, we need to stop doing that act. Now, it's easy for me to say, of course, but this technique actually works very well. Either stop out loud or snap a rubber band on the wrist. Modeling, this is where we as a therapist, we act as a role model. Now I do want to discuss the two common subtypes of a behavior technique. The first one is systematic desensitization, and then the second one is flooding. We use that in anxiety, phobia, OCD, maybe PTSD. So we'll start with the systematic desensitization first. So the idea here is that systematically, slowly, stepwise approach, we want to desensitize the issue, whatever that the client is telling you. The client will be in a very relaxed environment. So when he or she has mastered the relaxation technique, we will slowly expose them to whatever that fear stimuli is, whatever that issue is, in a relaxed state, of course, and then we'll see how they do it. For example, let's say you have a client who's afraid to ride on elevators. He would rather climb 24 flights of stairs in an office building to avoid riding the elevator. Now the problem is his office is moving to the 32nd floor in a downtown area. So needless to say, now there's no way he can climb that many stairs. So he hires a therapist to treat his phobia. So A therapist selected a systematic desensitization technique. We will have the client imagine the entry level of the office building with a clear image of the elevator. Um, in the subsequent sessions, and always in a relaxed state, we will have the client progress to images of walking onto the elevator, having the elevator door open and close after he had entered. Maybe in the second or third time, well, the first few times I'll just have them to draw and then just imagine in the picture, in the images in the office, and we will just practice that. Okay, close your eyes, let's pretend that we are going to ride onto the elevator and press the button. Okay, we'll go to the first floor, and this is happening in the office, and and we'll say anytime you're getting anxiety, you can either open your eyes, or here's my hand, you can touch me or whatever, and then we'll practice that a few times. But then eventually we will do the field trip, and then we will go out, and then maybe um, go to the second floor, or maybe the fourth floor, something like that. So the eventually patient should be able to graduate and able to um, um, continue to use the elevator without having the need to sit down with you or take you with them. Needless to say, it's a process. It's so easy, stuff that you and may take for granted, but it's if this is giving them anxiety, and they are deciding should they give 2 weeks notice or quit, versus hire a therapist, those are difficult decisions that a client is making, because this is really giving them anxiety. It's not easy. Now, the second technique is the flooding technique, totally opposite of systematic desensitization. This is where a client is exposed to the feared object um, all of a sudden. You pretty much bring, I don't know about the real spider, but maybe fake, um, or plastic, or maybe real too. If the, and then you ask them, let me see your hand, and then you put that on their hand and see nothing happens. If the patient is scared of height, take them to Eiffel Tower, Golden Gate Bridge, Burj Khalifa. One technique that they do is with OCD client, if the main concern is the hygiene, and they feel the need to wash their hands all the time, so they can use a flooding technique where place a dirty item, either tissue or I don't know, whatever the object is, onto their hand, and not allow them to wash. So that would be, they need to learn that, right? So anyways, those are the two main differences. With the flooding is all of a sudden you're exposed, and with the systematic, it's a step up approach. Okay, so let's talk about pharmacological interventions. If non-pharmacological interventions either fail, or you just need to give them help to augment the CBT and so forth, we have options. So SSRIs is the best practice for the treatment of anxiety. We typically use, you can use any antidepressant, but we usually use SSRI as a first line. Zoloft, sertraline, paroxetine is a good one. Fluoxamine and escitalopram are good antidepressant SSRIs that work very well. And remember, I told you earlier that amygdala is heavily innervated by serotonin. I was going to say sertraline, serotonin, and it's the overactivation of amygdala. So we need to actually when we give SSRI, what are we doing? We are preventing the reuptake, right? So the serotonin levels are going to be available here for a little bit longer duration so that we can calm down the amygdala. Sometimes that's all you need. You're trying to calm down. Okay, having said that, we need to avoid fluoxetine, which is a Prozac, and Wellbutrin, bupropion. The reason behind that is that both of them are actually activating. They can increase anxiety. Okay, so remember, Prozac is antidepressant, and we give Prozac, fluoxetine, to somebody who's depressed and has no energy. When we give Prozac, a patient feel a little bit energetic. You know, they wake up, and that works very well for a depressed client in a vegetative state. Same thing with Wellbutrin. But here, the client is already energetic or has anxiety. You do not want to further increase their anxiety. So this would not be a good choice for these patients. Okay. As we know that SSRI will take several weeks to work, right? But if the client is anxious right now, today, the client is not going to take a medication that will help them in 2 weeks or 3 weeks or 4 weeks or so. So it is very, common practice to start your patients on benzodiazepine. Now, benzodiazepine work very quickly, as we know, but they're also very addictive, right? So SSRI or antidepressant is still the best practice, and we should start with that. But it's acceptable practice to also give them benzodiazepine for maybe 7 to 10 days or so. The idea is that you give them benzodiazepine and let them know that this is temporary, this is only as needed, and eventually SSRI will kick in, and then I'm going to taper you off of a benzodiazepine. We should not be managing anxiety with monotherapy of a benzodiazepine. You will never be able to treat that because this is such a short-term, short-acting, medication. So rule of thumb is, at least what I do is I give both SSRI, and I give them good patient teaching that I'm going to take your benzodiazepine away from you, or maybe give you as needed, maybe PRN here and there for if you're having a bad day, if you will. Okay, so the way benzodiazepine work, they enhance GABA. So if this is your typical cell, as we know that the resting membrane will be negatively charged inside, right? But if the client is anxious, now you have a positively charged. That's this anxious cell, right? So when we take a benzodiazepine will work on GABA receptor. This is GABA. So GABA receptor will when you bind the GABA receptors, the gate will open, or the channel will be opened, and then chloride ions enters. And remember, chloride is a negatively charged. So when you increase the frequency of chloride ions, because you opened this GABA with the help of benzodiazepine, you are reversing the charge. Instead of positive, you're creating more negative charge, and that's what you wanted, right? You wanted this patient to be calm and rest. So now this membrane or this nerve cell is resting now, and that's how we minimize anxiety. It's the same principle for tremors, same principle for seizures, anxiety. It's the same pathology and same treatment, if you will. That's why benzodiazepine, like Ativan, works very well for seizures as well. You're going to reverse the charge here. Just remember, resting membrane is a negatively charged, and that's what you're trying to achieve by adding more chloride ions. All right. So as I mentioned earlier, the the principle for benzodiazepine treatment in case of anxiety is that it's okay to treat acute symptoms or maybe sometimes insomnia, but as we know that it has a abuse potential, so we want to minimize the use, and especially if a client takes alcohol. So it's a patient teaching and that needs to be documented. You told the patient, I'm going to give you this for 2 weeks, you cannot drink alcohol. Remember, you may have a client who's very anxious or depressed and is using alcohol as a type of coping skill. That would be a maladaptive pattern, of course. So we need to identify that and do a patient teaching, because otherwise a combination can have a very, very fatal outcome, respiratory depression. The problem with benzodiazepine, number one, is very addicting, and number two is that depending on which one you pick, they have a different half-life, so they are not going to stay in the system forever, and the cycle continues. For example, alprazolam, which is a Xanax, has a very short half-life, so you need more frequently. So the recommended dosage is very small, 0.25 milligram 3 times a day, and it really should be PRN, and that's what we want to let them know. If you don't need it, you don't need it, right? Now the intermediate would be like Ativan, lorazepam, so that should be BID, 0.5 milligram BID. Then a little bit longer acting, maybe a clonopin, clonazepam, 0.25 BID, and this is kind of long acting. The point I'm trying to make here is that if the patient only complains of anxiety maybe once a day, or it's very specific when they travel or whatever, then perhaps they'll be okay with just 1 dose of alprazolam. It's a short acting, it will kick in, it will disappear from the system. But if you have a patient who has anxiety maybe throughout the day, they may need maybe a little bit longer acting, but definitely need SSRI along with that, because think of SSRI as your base therapy, and this should be really used as a breakthrough PRNs. Okay, another treatment approach is Buspar. This drug was released in 1986. It actually works on your serotonin receptor as a partial agonist, so it's going to increase your serotonin level. Remember that's what we wanted for amygdala, remember? So, and there's no evidence of dependency, so there's no potential for that. The issue here is it doesn't work immediately, unlike your benzodiazepine, right? And the onset is very quick. Here it's a delayed effect. It takes several weeks, and it does have a short half-life, so it needs at least BID, if not TID treatment. So this can never be taken as a PRN, so that's a disadvantage. So it requires a multiple doses regimen, as I said, maybe BID, if not TID. Slow onset of action, and it's a bit expensive. So that is actually one of the reasons it's not really widely used in psychiatric practice. However, in my opinion, it is actually a good drug. My approach would be to use this with a combination of a benzodiazepine. Just like, remember I said we should start, number one, my approach would be, let's start SSRI as a base, right? Number two, we can either do buspirone and then use benzodiazepine, prescribe benzodiazepine at the same time, and let them know that I am going to taper you off of a benzodiazepine once buspirone kicks in, which probably will be in I don't know, 3 to 4 weeks or so, and then we'll start tapering the client off. It actually, if we combine buspirone along with the benzodiazepine, you'll be surprised. You probably will get a very good result as compared to buspirone as a monotherapy or benzodiazepine. Well, definitely benzodiazepine as a monotherapy, we are not going to get a good result. They would have to just keep taking that higher and higher dosages. That's never a good thing. Don't do that, please. Okay, next agent is venlafaxine Effexor. It's a SNRI. Um, so it's a serotonin norepinephrine reuptake inhibitor. The interesting thing about this drug is even though this is an antidepressant medication, but it's very effective in managing anxiety and even insomnia. So sometimes you have a client who has depression, let's say, or a generalized anxiety disorder, and they have a symptoms like a muscle tension, and the client is very irritable, or insomnia and so forth. Then this is a very good drug. I use that a lot. Anytime I have a client with a mixed anxiety or generalized anxiety disorder, and maybe along with depression, or even without a depression, um, I have good result with this drug. Um, it is available as extended release, and so don't use IR. Now I have been using extended release. This is better, therapeutic effect. Okay, then we can do beta blockers. We for to minimize anxiety, like a propranolol, 10 milligram or so. Um, I use that a lot actually in my practice. Uh, it will help your client to calm down. This is not going to be my first line, of course, but if I have a client who's very agitated, very anxious, and I already have this patient on maybe one or two other medications, then I will add, these are adjunct medication, I will add a beta blocker. Alpha 2 agonist, such as clonidine or guanfacine, are also a pretty good drug. Actually, I have seen good result, especially in children. You can use clonidine. I use that with adults, not necessary with the geriatric population. But if the client is again reporting anxiety with agitation, aggressive behavior, then we can consider clonidine. And remember, because it's alpha 2 agonist, then the alpha 2, they cause vasodilation. Remember, alpha 1 cause vasoconstriction, and then alpha 2 dilation, right? So these are alpha 2 agonist drugs, so further dilation. So blood pressure can go down. So double check the from the cardiovascular standpoint of view, make sure the patient is stable. And most of these kids or even adults are a healthy individual. Rule out the other medical stuff, of course. Some other adjunct treatment, antihistamine, gabapentin, Lyrica. I really don't do too much barbiturates anymore, like a phenobarbital. Those are old drugs. The mechanism of these drugs are very, very similar to the benzodiazepine. The only difference would be with benzodiazepine. Remember, they increase the frequency of chloride ions, right? But with barbiturates, they increase the duration of chloride ions. In other words, if this was a cell, here's a GABA channel. So with the phenobarbital or those barbiturates medication, the chloride will enter. It will stay for the longer duration. versus with benzodiazepine, you're increasing the frequency of chloride. So minor difference. I don't use this, to be honest with you. We have a better options now, but that's there for your reference. So that was anxiety. Next stop is obsessive compulsive and related disorders. So they're also grouped together. They share the same theme. The underlying theme is really anxiety again, So we'll talk more about OCD, but then you have a body dysmorphic disorder, hoarding disorder, and hair pulling and skin picking and so forth, substance or medication used. Take a look at that. Okay. OCD, obsessive compulsive disorder, you have two components. One of them is obsession and then compulsion. We'll talk about them one at a time. We'll start with the obsession. The definition of the first component is that you have a client who has a persistent thoughts, urges, or images. In other words, they are thinking about something and it's causing anxiety. And the second part of the definition is um, they're making attempts to ignore that thought process or that urge, but they're not able to ignore it. They want to ignore it. They're not able to ignore it because it's causing anxiety. Now, remember, underlying theme for these disorders is going to be anxiety. It doesn't matter what disorder we pick under these. For example, hoarding disorder or hair pulling, skin picking, and so forth. The common theme is going to be that the client is anxious. So therefore, the treatment approach is also the same. Counseling, for example, and then CBT, and then SSRIs. So they work on all of these disorders because the common theme is the same, right? Okay, so coming back to the OCD, you have a client who has a thought. For example, thought could be that let's say you have a client who's driving to work, and then he or she believes that I wonder if I turn the gas off or stove off, or I wonder if I left the front door open. Is my garage door open? Are the lights off? So it's a thought, and they're driving to work, and it's bothering them, and they're trying their best to ignore it. But when they ignore it, it's giving them anxiety. It's increasing the level of anxiety. So that's obsession. Now, if they continue to drive and go to work and has no impact on it, then it's really not a disorder, right? But well, if it has an impact on them, on their ADLs or the work performance, then yeah, then that will be, then they're meeting the criteria. But if there's no impact, then we really don't we don't prescribe medications, we don't give a diagnosis, they're not going to meet the criteria. But let's say that the anxiety is so huge and the impact is so huge, and they make a U-turn and they go back and check the front door or the garage or the lights and stove and all that stuff, right? Now they're acting on it. So the minute they act on that thought, then they're meeting the criteria for compulsion behavior, compulsions now, which means that now they're, it has to do with the behavior, they're doing something. For example, triple checking or hand washing many times. Um, um, and why are they doing that? Because it is that's how they decrease their anxiety. A client doesn't have to have a both, by the way. They don't have to have obsession and compulsive. It's one or the other. But most of the time, the client will have both. In other words, they will have a thought and they will act on it. And most common, I'm sure you have heard, hand washing is, or taking long showers. And now, up to some degree, people just joke around and say, well, I have OCD and so forth. And now, there's a difference between you have rules and regulation, and you're a very highly organized person perhaps, and those type of personalities or traits are highly recommended, and we praise those people who are very well organized, but that's not a pathology because there's no negative impact on their ADLs. Once these rules and regulations um, and these things are so rigid and have impact on your ADLs, then that becomes a pathology. So just take a look at that. Now you're meeting the criteria. Make sure it's not caused by something else, not by another disease or disorder, and so forth. Now, one thing I just would like to mention here is that depression is a very common comorbidity with the client with OCD. So we really need to identify that as well, anxiety and depression. And I gave you a handout in Canvas to use Yale Brown Obsessive Compulsive Scale. Okay, so how can we help these clients? Well, the first one on the list is CBT, systematic desensitization or flooding technique. We already talked about CBT. So talk therapy, we need to identify, the person needs to acknowledge that and identify and then work on those skills. Antidepressant, to be honest with you, they work very well. Pretty much all SSRI, have been used at one point in these clients, but more specifically, fluoxetine, sertraline, paroxetine, fluvoxamine, they are prescribed. One thing I'll tell you is that when we are using antidepressant for OCD, we do need to give higher doses than if the client you were treating had depression alone. So if it's just depression, let's say that you wanted to give 10 milligram of something for depression, but the dosage for OCD should be 20 milligram, let's say, for the same drug. And TCA, I do have actually a few patients on that. Clomipramine, it's not a first line drug, of course. We always start with SSRI, but I do have a patient, I had her on SSRI for several months and pretty high dose, and things were not making, she was not happy with it. The way we anticipated the response, so we switched. She wanted me to actually try TCAs, and we had a conversation. We talked about the side effect. It's we know this is not as clean as SSRI. She was okay with that, so I think she's on this now for 6 weeks or so. Last time I saw her, she was happy. She was tolerating it very well, so we'll see. Hoarding disorder, it begins in childhood and lasts a lifetime. This is where the client will start collecting excessive, collection, and leads to extreme clutter and becomes a safety issue. Fall, infection, you name it. When I make rounds at nursing homes, we sometimes here and there we come up with these issues. Treatment is again, CBT. We sit down with them, talk about that, and treat the underlying or comorbidity that goes along with it, either depression, anxiety, whatever the separation anxiety. There's a concept of declutter and minimalism. I go over that. There was a case that a lady had a bunch of items at home, and the home health nurse comes in for like a wound check or something, and she reported that this is unsafe. Social worker came in, They sat down. They found a magazine, old newspaper from like a 1965, early. And she said, "Oh, yeah, I need them. Maybe one day I need them. And there was a piles and piles of paperwork and stuff like that. But anyways, she was having anxiety to get rid of them. So again, anxiety is the underlying theme here. So they came up with this neat idea that what if you make two piles, and one that you really need, and then the second that you can really, you can get rid of. So she was able to make few piles, but then the one that she needed, then they said, well, why don't we just take some pictures and picture these old magazine and so forth, so you can have a digital copies now, and you can always revisit them if whenever you need them, and then perhaps we can shred them now, since you have a copy. So they were able to actually clean it up. So involve social worker and some other members of the team if you are dealing with that, because this is important, and this can cause so many other issues, fall, broken hips, and infection, and so forth. Okay, last one is sleep wake disorders. So there are a bunch of categories, if you will. Pure insomnia, and then and so forth, and then you have a hypersomnolence disorder. Okay, well, we'll start with the sleep wake disorders. Um, as you know, sleeping, eating, and eliminations are the basic human drives. These are the good indicators of a good physical and mental health. As a matter of fact, we believe that sleep is the psychiatric vital sign. It's so important to really assess our patient, evaluate, and treat if they're not able to sleep. And the first question, one of the few questions that I ask up front is, when I say, how are we doing today? And I ask them, tell me more about your sleeping habit, sleeping pattern. Are you sleeping okay? Are you eating okay? Are you sleeping okay? Are you pooping okay? Those are the three questions I usually ask. That tells you a lot about their overall health. If the patient is not able to sleep, you can only imagine the differentials at that time. Okay, so we know that the sleep can be divided into two physiological states. Your non-rapid eye movement and rapid eye movement. And then your non-rapid, start with the stage one. This is where, yeah, it's time to go to bed. You're a little bit tired, drowsy. You're still awake though. When they do EEG, the sleep studies, you see those stage, images, and you know that the patient is on stage one. Then the client enters into stage two. This is your light sleep, another 20 minutes or so. And then we are getting into a little bit more deep, moderate sleep. That's a stage three. And then deep sleep would be stage three. So all three, 1, 2, 3, 4, we're still under a non-REM stage, if you will. And then you enter into so this is a deep sleep, by the way, the last stage of non-rapid eye movement. And then under rapid, this is the fifth one. The entire body is pretty much shut down, if you will, but you have a rapid eye movement, and this is the time when most the dreams occur, and so forth. And then the cycle continues pretty much. Then you go back to stage one, pretty much in the same order, if you will. And then you can have, like, I don't know, 4 to 5 cycles or so, and cycle continues. So that's a typical sleep cycle. Okay, so the neurobiology of sleep-wake cycle is that the story begins with the thalamus. Thalamus will regulate the on or off switch. The on switch that we call wake promoter, and then the off switch is a sleep promoter. That makes sense. So the on switch is actually regulated by histamine on the orexin 1 and 2 neurons. So there you are, you have neurons here running, and two subtypes, orexin 1 and 2, and they're actually under the influence of histamine. Histamine is regulating. Histamine here is acting as a neurotransmitter. We all know the role of histamine as during allergies, right? Runny nose and so forth. But histamine is acting as a neurotransmitter to act on an on switch. The off switch is actually regulated by GABA. So GABA neurotransmitter acting as a inhibitory. It's going to give you, that brake pedal, if you will, here, right? So that's one concept. Second is, the pineal gland also secrete a neurotransmitter called melatonin. So it is acting on SCN and working as a circadian rhythm, or our natural clock or pacemaker, if you will. So here's the criteria, DSM criteria for insomnia. You have a client with a predominant complaint of dissatisfaction with the sleep, quantity or quality. In other words, they are not happy, right? And they either have a difficulty initiating sleep. In children, this may manifest as a difficulty initiating sleep without caregiver interventions. Or you have a difficulty maintaining sleep, so initiating or maintaining. So the client is going to frequently wake up, or a problem returning back to sleep. Okay. Early morning awakening with inability to return to sleep. The sleep disturbance cause a clinical significant. We know that there has to be impact. The sleep difficulty occur at least 3 nights per week. So that's the criteria. The sleep difficulty is present for at least 3 months. This is going on for the past 3 months. And the sleep difficulty occurs despite adequate opportunity for sleep. In other words, it's not because you're working a 24-hour shift, or so you were in your room, you tried your best, you have time and opportunity to sleep, but you couldn't for the past 3 days in a week, and it's going on for the past 3 months. Okay, and you're not happy either with the quantity or the quality, and there's impact on the ADLs. That's pretty much is the criteria. And then take a look at, make sure it's not caused by something else, and so forth, right? And specify that. So what's the treatment for insomnia? Well, just like everything else, we start with the non-pharmacological interventions first. There's a concept of sleep hygiene that I discuss with the patient, and I'm sure you know this very well. This is pretty much to establish a routine for the bedtime, minimize any kind of stress, or have a regular time to sleep and wake up. I tell my patient, bedroom is used for 2 reasons. Number one is to sleep, and number 2 is to make babies, and that's it. So bedroom is not where you want to watch TV or eat, or I don't know, be on the phone. That's not what the bedroom is for. So anyways, just talk about sleep hygiene altogether. Relaxation technique, biofeedback, meditation, and CBT. We tell patients, or at least I tell my clients, rule of 3, 3, 2, 1, I'm sorry. There are 3 things you have to worry about. Number 1 is no eating 3 hours before you go to bed, no exercise 2 hours before you go to bed, and then no electronics before you go to bed. So these are 3 E's: no eating, no exercise, and no electronics. 3, 2, 1, that's a rule of thumb. We know how bad it is that we all are glued to our electronics, our cell phones. That's not a good thing. We all know that, of course. We just need to work on it. The reason behind the exercise is that, you know, if you're exercising right before you go to bed, or eating, then your temperature, you're going to have a warm temperature, and then the body doesn't like that. We go to sleep, you know, when the internal temperature is lower, is decreased. Okay. Benzodiazepine, the one that I uh, discussed during anxiety slides, can be used for insomnia. However, same problem, it's addicting. There's half-life issues, so it's never a good, I shouldn't say never, but it's usually not a first line treatment. It should be second line treatment, or maybe third line, I don't know. The problem with half-life is that for the benzodiazepine, it's either too short, you know, like a Xanax, or, you know, maybe Ativan. So it's going to cause, you know, the patient to just wake up in the middle of the night, and the patient is going to have a difficulty to go back to sleep. Or you can have a benzodiazepine that has a too long half-life, so it's going to cause sedation even the next day in the morning. So that's a problem if you're driving or working with the machinery and so forth. Another problem with the benzodiazepine is it will build up some tolerance, so now you need more drug, so that's another problem. Another issue with the benzodiazepine is you can have a withdrawal effect, so it's going to cause rebound insomnia. And rebound insomnia is when now you really can't sleep, and now it's actually a bigger problem than you started off with. Maybe you were able to sleep a little bit, and because we used benzodiazepine too much now, and now we really can't. So as you can tell, it's never a good idea to have a benzodiazepine as a monotherapy. Otherwise, you'll be just keep increasing the pill and not getting a quality of life, and have some you know, a cognitive decline on, to be honest with you. The examples, if you have to use, you can use a short-acting medication or intermediate. I know that we use a Restorol a lot, or the long-acting, but in my opinion, if you have to pick intermediate. Okay. Same thing. I know people use barbiturates. I don't, honestly. It's a very old, that they're not used anymore. We talked about a mechanism of action. It increase the duration of chloride ions. Phenobarbital is example, just like a benzodiazepine, not a good drug. Now, so what is the first line, you know, after non-pharmacological interventions? Z drugs, you know, they're called Z drugs because they start with a Z, at least these two, and this one also has a Z in it. So anyways, how creative. So they work on a GABA A. So these hypnotics drug, they will enhance GABA activity. So if you're going to enhance the activity of GABA, you're going to calm your patient, your nerves, if you will. So they work very, very similar to benzodiazepine, but they're a cleaner drug. They do produce a very restful sleep. They're not really addicting. They are more expensive than benzodiazepine, but in my opinion, are better. They're go-to drugs, or should be go-to drug. I would rather put somebody on Ambien instead of Ativan. I think that's the message here. Here, this one is a short acting, this is intermediate, and this is a little bit long acting, more expensive as well. Okay, so other drug classification is melatonergic drugs. They work on melatonin sites, MT1, MT2, and MT3. The example is very well-known example, over-the-counter melatonin, and of course we have melatonin as the prescription drug. Both of these drugs, they will work by inducing the natural sleep cycle. Um, it will not help the client to maintain their sleep pattern. What do I mean by that? So when you have a client who comes into the office for insomnia, one of the questions we are supposed to ask is, so tell me more about it. Tell me, are you able to fall asleep, or do you have a difficulty falling asleep? Or do you have a difficulty maintaining it? If the patient tells you that, oh no, I just can't fall asleep, I have 6 to 8 hours that I would like to spend in my bedroom, and I am just laying there looking at the clock, and I just fall asleep. Well, the first thing we need to tell the client is not to look at the clock. So, and talk about sleep hygiene. But the point here is that patient might be or that client might be a good candidate for these drugs, because it will help them to induce that natural sleep, if you will. But if the patient tells you that, oh no, I have no problem falling asleep, or I'm able to fall asleep, but then I wake up after 3 hours, 4 hours, or in the middle of the night, and then I can't go back to sleep, then they're having issues to maintain the sleep. So this medication or these agents may not work for those clients. So you perhaps want to consider those Z drugs that we talked about earlier. Um, or we can offer antidepressant medications such as trazodone is a good one in this setting. So remember, trazodone is anti-depressant medication, and we talked about this earlier, that trazodone, in order to work for antidepressant, you have to have at least a BID or TID dosage, and the problem is the side effect of trazodone is sedation. And well, that's never a good thing to take a medication 3 times a day for depression, and that gives you sedation. But what we can do is we can take advantage of sedation as a side effect and turn that into a therapeutic effect, if you will, and take this medication at bedtime, a low dose at bedtime, because we are not treating depression at this time. Another interesting point here is that it has a half-life of 6 to 8 hours, and we actually take advantage of that because that works very well for our client who wants to sleep from 6 to 8 hours and really doesn't have a sedation day after, or in the morning, I should say. So it works very well for adult patient. Be very careful with elderly clients, as we know that geriatric patient, um, they do not tolerate these medications. They may have a sedation the next day, or they want to wake up in the middle of the night to go to the bathroom, and they may have fall and break their hip. So be very careful with elderly patient, geriatric patient. But for adults, I have seen this a lot for young adults. Okay, mirtazapine, another antidepressant medication. As we know that the side effect of mirtazapine is sedation, so we take advantage of that. Mirtazapine is a good drug that will minimize your anxiety, insomnia, depression. It also helps with increased appetite, so weight gain. Um, so very another tool in your bag, if you will. Remember, these patients are coming in as a for you to see as a specialist. So we should have multiple options and feel comfortable about these medications. TCAs is another drug, or a classification, I should say, amitriptyline, especially if the patient has some neuropathy type of a issue along with insomnia, depression, and go with the TCA. That's not my go-to drug. I try my best to avoid TCAs, but if we have to, then of course we can. Um, I would rather pick trazodone, to be honest with you, over TCAs. Another classification is a histamine H1 antagonist. Remember, we have histamine, um, as a neurotransmitter here. Remember the role of histamine, like H1, H2, H1 in the respiratory tract, and then the role for in case of what do you call when you have allergic reaction and so forth during allergies. So that's your H1 in the respiratory, and then H2 in a GI tract. Um, but here we are talking about histamine from a neurotransmitter standpoint of view. As I mentioned earlier, that histamine regulates that on switch. Remember the on and off, and I said histamine will drive the on switch, and GABA will work on the off switch. So this on switch is considered as like a something that's going to promote wakeness, right? So wake promoter. And if we give histamine antagonist, then we are going to block the on switch, if you will. And so we know that the Benadryl, Vistaril, these are antihistamine drugs, if you will, antagonist, you can say. So they cause sedation, so they're going to turn this thing off, if you will, right? Okay, another interesting drug is a dual orexin receptor antagonist, DORAs, like a newer concept, if you will, from a medication standpoint of view. So remember earlier I mentioned that this on switch is even though it's regulated by histamine, but you do have orexin. I said orexin neuron, orexin 1 and 2. These neurons are responsible for that wake promoter, and it's under the influence of histamine, of course. So these drugs, for the drug that we have is Belsomra as a brand name, so Orexant generic. They actually work on the orexin and cause antagonist effect. So orexin receptor antagonist. In other words, they're going to block the on switch, and they are very selective by doing so. Selective antagonist. What do I mean by that? There are some other neurotransmitters here that will also play a role, such as acetylcholine, dopamine, and norepinephrine. So this drug, these agents, they are selective. In other words, they will not block the rest of the neurotransmitters. So you're not going to see the side effects that will you see from blocking the acetylcholine, like anticholinergic type of side effects. So you won't see it. It's a clean or a cleaner drug, very selective. It's a newer, so it's more expensive, of course. Interesting stuff. Okay, then you can have a client with some comorbidities, such as maybe insomnia with restless leg syndrome. And my advice is to prescribe gabapentin, or at least consider that. Maybe Lyrica if GABA is not effective. Start at nighttime, so that they tolerate. That they're going to tolerate the medication, and then maybe add the noon dose for gabapentin, and maybe then TID, 300 milligram TID, and so forth. But increase the dosage at the nighttime, because if the main goal is insomnia. Anytime you have a client with RLS, restless leg syndrome, double check their hemoglobin. Sometimes, if you have a low iron saturation, and then you can have some presentation here, similar presentation. So keep an eye on the hemoglobin, iron, and then do the supplement if needed. Okay, I do want to talk very briefly about the nightmares. Sometimes you can have a client who has some history of a trauma, maybe PTSD, severe anxiety, some kind of a trauma, and they're not able to sleep. And then if they sleep, they report nightmares. Then one of the drug that I use a lot in this setting is actually alpha 1 adrenergic blocker, prazosin. It tends to increase the total sleep time and the REM sleep time as well. So this medication, I use that a lot. I have a good result. So keep an eye on this. Okay, now the opposite of insomnia. Now you have a client who's sleeping a lot, sleeping despite the fact that they had good night's sleep, at least 7 hours or so, but now they feel sleepy within the same day, difficulty being fully awake. It's going on for the past 3 months. Okay. So what's the treatment for these patients? Well, it's going to be totally opposite of your insomnia treatment, right? So we're going to give them something that will stimulate. So caffeine, modafinil. Now the interesting mechanism of action for this agent would be the totally opposite of Belsomra drug. Remember the agent that we just talked about, it will turn the on switch off. Here it will actually promote the orexins neuron. So it will actually increase or promote, you can say, that wakeful cycle or a switch. So it's going to work on the on switch, and that's what we want, right? And of course we can give them a stimulant. We'll talk about amphetamine and so forth when we discuss ADHD lecture, but just for now, just understand that we can use that. Be careful, make sure the patient doesn't have a substance use disorder or some some issues with abuse before we prescribe stimulants, of course. And then the last one here on the list is gamma hydroxybutyrate, GHB. This is actually naturally present in our brain. It comes from GABA. Sodium oxybate is the name of the agent that we can use for a client with excessive daytime sleepiness. The issue with this agent is it has a high potential abuse, so be very, very careful. Needless to say, it's a controlled drug. It's also sometimes called as a date rape agent, so potential for abuse, be careful. And sometimes some athletes, they may also use this or maybe abuse this or overuse to enhance their performance. So something to keep an eye on. And off-label, we use that for fibromyalgia. And I think that's all I have. As usual, if you have any questions or concerns, please do not hesitate to contact me. Thank you so much.